going to make a start. Some people might still be joining, but they can just slip in. So I'm just going to talk about hypertension, renal causes and management of this. So just objectives of this session. I'm going to look at classification, and I can't talk about treating hypertension without talking about measurement of blood pressure, when to investigate for hypertension and cutoffs, overview of some renal causes of hypertension. Oops, sorry. What investigations should be considered, and when to refer to a tertiary centre or speak to specialist nephrologists for advice. So, classification of blood pressure. The main ones that you will find used in paediatric practice are the European Society for Hypertension Guidelines and the American Academy of Paediatric Guidelines. So, definition of hypertension in children is quite arbitrary. It's based on normal distribution of blood pressure in healthy children, whereas adult definition of high blood pressure is very much based on cardiovascular morbidity, mortality, and this associated with certain level of blood pressure. So diagnostic criteria for an elevated blood pressure is based on the concept of increasing age and body size of children. So you'll find a lot of children, naturally, they'll have an increase in their blood pressure when they reach their stages of puberty. So just looking at centiles, these are the Flynn 2017 American centiles. So these are classified for children aged 1 year to under 13 years. And then for children aged over 13 years, they go by the adult figures. So it's split in between normal, elevated, stage 1 and stage 2. You might also hear the elevated stage being called pre-hypertension or high normal. So the difference between these and the European ones is majority of, for the ones of the children aged 1 to less than 13 years, they have a split classification as soon as you get to the elevated stage. So you can see there it says about systolic and diastolic over the 90th percentile to under the 95th, or figures of 120 over 80 to less than the 95th percentile. And we just go by whichever one is lower. The European ones then are, I find, slightly more easier to interpret. Their differences, they are based on children from age 1 to 15, and then for children age 16 and over is their adult classification. And these ones have a bit more clear cut. They're not either or with percentiles or figures you'd be obtaining. Pretty much similar with the reference to over the 90th or equal or under the 95th for the elevated, and so on. So the European guidelines, I think, are the ones that are most used in practice now, purely because the whole guideline itself, not just the centiles, is quite easy to understand. It's quite logic, and I've attached a reference at the end if you'd like to have a look at it. But the European data was looked at, compiling it together through a lot of international studies that were done, through some cross-sectional surveys. So it's about 7 different countries. But the problem is with these is they age their parameters from age 6 to 19 years. So actually the European guidelines go a lot on what the US guidelines have done, and they use a lot of the normative data from those who look at the age restriction as low as the age of 1. And the reason why these international guidelines weren't used for the European ones is because of the variations of population, the age restriction, diet, activity, genetics, lack of outcome data from these studies could limit the clinical applicability. So looking at the centiles and thinking about measurements of blood pressure, you can't think about treating blood pressure without considering accurate measurement. It's a really important aspect in diagnosing hypertension through accurate measurements. And we all know that hospital has a lot of influences in paediatrics in the measurements of their blood pressure. So one of the ongoing debates, and I think it will always be ongoing, is oscillatory or oscillometric for accurate measurements. The difference being oscillatory method of measurement listens to your carotid sounds, so your systolics of K1, your diastolics of K5, while deflating the cuff. This can be specifically difficult in neonates or younger infants. You may hear their diastolic at K4. The oscillometric actually measures your mean BP from your point of maximum oscillation. So neither systolic or diastolic are measured directly. And a lot of the automated monitors are calibrated under certain calculations based on the mean blood pressure. So how does this bode a problem for paediatrics? Well, the automated monitors, the very few of them are actually validated in the paediatric population. Reference values defining blood pressures are actually then based on oscillatory measurements. Hypertensive values that are obtained using oscillometric equipment, so if you're getting measurements in practice of blood pressures over the 95th centile, you should confirm these with oscillatory ones. So whether that be manual Doppler, stethoscope, palpation, oscillatory measurements should then be attempted when obtained high readings on the automated. So just a little bit more about measurements and the accuracy. We get a lot of referrals through when they come to us. We always specifically ask, where's the measurement been taken? So arm versus leg is the common one. Sometimes it is necessary. Sometimes you may have children in practice that have numerous lines in their arms. You may need to check their leg measurements anyway if you're considering coarctation and evaluating for the differential blood pressures between upper and lower limbs, or a peripheral vascular disease and the difference in blood pressure in the legs. However, they shouldn't be used interchangeably, so we would always recommend measurements to be done in the upper limbs. Measurements that are done in the legs can be upped in a normal child that doesn't have a coarctation or peripheral vascular disease, can be up to 20 millimeters of mercury higher than the upper limbs. Sitting versus supine is also another one. So supine has higher readings and a lot of children in hospital will be supine anyway. So ideally we should try and get the child to sit so we can measure their blood pressure in the sitting position. And this is because these values are then normative to the ambulatory setting, say at home or out of hospital environment. So correct cuff size is another important one. So inflatable bladder must cover 80 to 100% in the arm. A lot of the time, blood pressure cuffs that are used in children are too small, and too small a cuff will overestimate the blood pressure. So I think the cuffs are difficult because a lot of them say adults, and you may look at a 5-year-old child and think, why would I use an adult cuff? But actually when you try and fit it then around the arm, that is the size that fits the child. Overcuffing is less of a problem for measurements of reading. We would rather have measurements with a larger cuff than a smaller one. And then this table I've included in the bottom, there's a reference at the end. It's a Sutherland study from 2018 that just looked at the comparison of the 95th percentile of blood pressure in the ambulatory setting compared to the critically ill child. So it's just really important to consider when we're measuring blood pressure, the accuracy of that, and knowing that children as inpatients are likely to have a higher blood pressure than their normal from the ambulatory setting. Another thing that can influence blood pressure, especially in infants, if we're thinking of feeding. So there was a study done not so long ago about neonates and infants up to the age of 6 months. When they're feeding, blood pressure can increase to as high as 20 millimeters of mercury compared to when they're at rest, which is quite a significant amount if you think about it, especially for a neonate and infant. And then also the position of the cuff where the arm is. So the arm should be vertical to the body. So the more horizontal the more vertical your arm is, it can raise an increase of 5 millimeters of mercury for a measured systolic pressure. It's just important to note those when we're looking at trends of hypertension and blood pressure readings. So hypertension, very much in the literature classified as primary and secondary. So primary, we obviously do need to take into account because there is an increase in incidence of obesity epidemic in children and adolescents at the moment. Should also consider moderately heritable BP from genetic factors, so family history of hypertension. And then secondary, which is going to be the focus of this presentation. So majority of childhood hypertension is likely to have an underlying cause. So a lot of studies report prevalence as high as 75 to 85% of younger children will have a secondary cause to their hypertension. The most common form of secondary hypertension is renal parenchymal disease, which we'll go into later in this presentation. An important note of this is the likelihood of identifying a secondary cause of hypertension inversely relates to the age of the child and directly relates to the degree of blood pressure elevation. So just important to keep in mind when you're doing history taking, you're looking for other signs and symptoms, to use this as a general rule of thumb for assessing the hypertension. So what are some of the age-related causes? So I've just split these up into kind of the most common or not so common ones you may see. So neonatal to a year, CACUT, so congenital abnormalities of the kidney, urological tract, and with that AKI. Wilms tumour may also be one you see in practice. Renal artery stenosis, renal vein thrombosis, both can be in the younger infants, usually from traumatic birth injuries or if they've needed umbilical catheters. And then your polycystic kidney, so specifically in the younger years, you're going to see the autosomal recessive polycystic kidney disease. Age 1 to 5 years, you may see mid-aortic syndrome. You may see glomerulonephritis, particularly maybe post-infectious. You may see atypical HUS and normal HUS. And then 5 to 10 years, you may see some genetic causes. So things like the Williams syndrome, where they could have a structural abnormality or a vascular influence. Your neurofibromatosis, so where you get tumours along your nerves, this can cause a vascular form of hypertension. And then your other generic renovascular diseases, so things like the renal artery stenosis. Reflux nephropathy, so also renal scarring. This is probably more commonly known as renal scarring secondary to a VUR, which may be a dysplasia from infancy, which is only picked up kind of at the mid-child to early adolescent years. And then nephronophthisis, so a tubular interstitial problem of the kidneys, would also present at this age, which is also genetic. And then 10 to kind of adolescent adult years, all of the below can be applicable, probably less so the renal vein thrombosis or the mid-aortic syndrome, which will present in early infancy. You may also see some renal adrenal tumours, so things like pheochromocytomas, which affects the adrenal glands and causes an increased release of catecholamines. You may also see in this age group exogenous hypertension, so drugs that have directly affected the kidneys. So these are just some examples. So if the top left, you can slightly see the little bruised patches. So these are neurofibromas related to neurofibromatosis. And when you're examining, they feel kind of just like small lumpy bumps under the skin. They're not usually painful. There may be one or very few, or there may be multiple. They can come and go, they can reappear as larger, they can cluster, they can be on the limbs. the torso, and they can appear as kind of freckles behind the ear. And then just to the right of that, that's an example of an angiogram of a child with mid-aortic syndrome. So you can see from that picture a thoracic imaging and an abdominal imaging. So one on the left being the thoracic, you can see the narrowing of the main aorta down the middle there. So it's usually the distal aorta all the way down that is affected, and then sometimes some stenosis within the heart. And then the picture to the right of that, you can see the abdominal image with the kidneys, and then the narrowing just at the top of that renal, where the aorta links into the renal arteries. And this can affect the majority of the major vessels. And then you are likely to see what you see in this image, which is a lot of collateral formation. Just below that one, you can see some cafeole spots. So another thing to look out for on your clinical examination. Can have a relative cause of underlying hypertension from a renovascular disease. And then these are just examples of kind of your cacuts, so your different types of obstruction that you may see in younger to kind of our age of 5 years. Below that is just a renal ultrasound of kidneys, and where those arrows are, you can see some cystic areas there, so an example of polycystic kidney disease. So first line investigations. So just thinking of, we've done our measurements, we've worked out that our blood pressure is over the 95th centile, and we've done continuous measurements, automated and both oscillatory, to confirm it. We've thought about our clinical examination, which I'll also come back to. What investigations are you going to do as a first line? So renal function bloods, so inclusive of a sodium, potassium, calcium, urea and creatinine, a full blood count, thyroid function, fasting lipids, and glucose if they do have an elevated BMI. And then you want to calculate their GFR. So we use the Schwartz formula for children who are over 3 months. And this is just so then you can see what degree of renal impairments they are. Do they have a chronic or an acute on a chronic picture that's causing the hypertension? A urinalysis to assess for protein, blood or leukocytes. If they have any of the following, such as proteinuria, you want to send an albumin creatinine ratio. A formal dipstick can give you a clue of the level of protein in their urine. So 3+ is typically 3 grams per litre of protein. But this is very much affected by concentration of urine. So you can get a false positive of proteinuria if you have concentrated urine, so this is just to bear in mind. So sending off a formal albumin creatinine ratio is most beneficial for accurate analysis. And then a renal ultrasound, so this is beneficial for excluding things like your Wilms tumour, abdominal masses, neuroblastomas, your renal cystic kidneys, or any type of dysplasia where you may have a affected cortico differential on the ultrasound. And then if you suspect, you may want to do an echocardiogram to assess for any end organ damage. So what would second line investigations look like? So these ones would be used if you're suspecting severe hypertension. So severe hypertension being 95th centile and over, so kind of stage 2. And you're suspecting target organ damage. So at this point, you would have discussed this with a kind of tertiary centre or consultant nephrologist for some advice. You may want to perform a fundoscopy to check in the retina, some plasma renin and aldosterone levels, plasma and or urinary metanephrines. Neither is more specific than the other. If you can only get access to plasma metanephrines, that is okay. This can help with the diagnosis of adrenal tumours or pheochromocytomas. Plasma random cortisol, urine steroid profile if you're suspecting abdominal mass, a urinary VMA or HVA to rule out neuroblastomas. And then if you have access, a Doppler ultrasound, and this is very useful for excluding any renal artery stenosis or mid-aortic syndromes. And then after all these, the investigations you may do if a child has presented with underlying renal problems such as UTIs, or on ultrasounds, they may have one kidney smaller than the other. You may want to do a DMSA scan or a MAG3. So this is just an example of a Doppler renal ultrasound. So when we're suspecting severe hypertension, and you can see the reduced blood flow to this kidney in the top image, and then at the bottom, this is what we call a tardus parvus waveform. So it's just assessing the blood flow, usually distal to the point of stenosis in the renal artery, measured on ventricular systole. And you would usually expect quite a rapid upstroke in here, and you can see that is quite fainted in this one. So this would show a likelihood of a renovascular cause of hypertension. So clinical history taking. Clinical history taking is important, and I've just put it in here because it's very easy to then relate to specific causes of renal secondary hypertension. So, for example, edema, history of UTI, unexplained fever, abnormal urine colour, enuresis, flank pain, dysuria, anything related to kind of urinary voiding, could suspect a renal disease or a condition that's related to, say, Acute and an obstruction. So your pyelonephritis is an acute problem, your acute glomerulonephritis, an AKI, and or these can be on top of an underlying chronic kidney disease. Hearing loss is an important one. So Alport's syndrome specifically affects the kidneys, and this can present in later childhood, but hypertension is one of the primary presentations, and you usually get alongside this ongoing or worsening hearing loss. So this is something to look out for. Cardiovascular palpitations or irregular pulse. So if this is accompanying a patient who's presenting with hypertension, it should ring alarm bells for kind of a catecholamine excess. And this is where you want to start thinking about a renal tumour. So do they have something like a phaeochromocytoma? Rash is another one which can present with a lot of renal problems and parenchymal disease. So it can be a sign of renal vasculitis. So conditions like your Henoch-Schönlein purpura or lupus, both of which present with hypertension. And then skin markings. So café spots, which we looked at earlier, can be a sign of neurofibromatosis or renal vascular disease, and these can be multiple or just one. The patient may just have one café spot, and it could be suggestive of this kind of disease. Recent medical history is important. So have they had things like a recent pharyngitis or impetigo infection? Have they had exposure to sources of E. coli? That's when you want to start thinking about hemolytic uremic syndrome and associated blood pressure, or like we mentioned before, the glomerulonephritis type picture. Neonatal history is also important. So have they had kind of a stormy neonatal birth history? Did they have any umbilical catheters, which could cause ongoing renovascular hypertension, both in the immediate post-catheter or quite later on as the child develops and grows? And abdominal bruit. Abdominal bruit is quite a clear-cut sign of renovascular disease. However, you can get renovascular disease whether they have abdominal bruit or not. So you may not always hear it. Sometimes can be quite difficult in the younger children. Family history of hypertension. So have they known any relatives that have had renal disease, maybe a background of polycystic kidney disease, which is also important to consider. So just looking a bit more specifically, so renovascular disease, I would say I see it a lot, so I'd say it's very common, but it's not. It's very rare. It accounts for approximately 10% of pediatric secondary renal hypertension. And children usually present with severe hypertension. So we're talking severe hypertension of kind of stage 2. And with this, it's then not uncommon for the children to present with a blood pressure of up to 200 millimeters of mercury systolic or more. Secondary symptoms you would then see with this kind of hypertension are cerebral symptoms. So you may see some facial palsy, headaches, cardiac failure, or in the younger children, failure to thrive. Blood tests you want to carry out if you are thinking of this. You want to check their renal function. Are they hypokalemic? Are they hypochloremic? Have they got a metabolic alkalosis going on? These are 3 things that are very much related to renovascular hypertension. Secondary tests that you may do, so your plasma, renin and aldosterone levels. So plasma renin is not sensitive or specific, but it is very useful in us analysing degree of renal vascular hypertension before we've done more invasive imaging. If you suspect renovascular hypertension, or if they present with the severe hypertension of stage 2, you should refer to a specialist centre. Acute management at the time of these patients is aimed around a slow reduction of blood pressure under the advice of a nephrologist. So causes of renovascular disease in these kind of children are the following. So fibromuscular dysplasia is one of the most common etiologies due to the non-inflammatory, non-atherosclerotic process. Your other one with the younger infants may be umbilical arterial catheterization, and other causes may be neurofibromatosis, arteriitis, so vasculitis type picture, renal artery hyperplasia, and mid-aortic syndrome. So as we discussed earlier, the segmental narrowing of your abdominal aorta. So this is just an example of an angiogram. So a gold standard diagnostic for renovascular hypertension is a renal angiography. So you can see here, this is an example of a child with fibromuscular dysplasia. And this is typically seen in an angiogram by a string of beads. So you can see in the middle there of the renal artery, it very much looks like a string of beads. And this is a specific sign we see on angiograms. So following on from renovascular hypertension leads us into to talk about acute hypertension. So your child may present with a variety of symptoms, or it may be an incidental finding. So they may come in for a dental surgery or anything, cough, colds, and have their blood pressure done, and you may find a high blood pressure. So the urgency or level of investigation will depend on their presenting history. Are they clinically unwell? Concern about organ damage is always paramount here. So when blood pressure exceeds 30 millimeters of mercury above their 90th percentile systolic, you want to be looking at end organ damage for the following. So for your heart, have they got left ventricular hypertrophy on echo with or without affected function? Brain, have they got signs of encephalopathy? Kidneys, do they have renal failure or a late stage, so stage 3 onwards of AKI? Or their eyes, do they have any retinopathy? So as a general rule of thumb to remember with these acute hypertensions is the presence or absence of the severe symptoms or target organ damage is more important than the absolute BP level. So if you think about how the child is presenting, if they may present with a symptomatic or an incidental finding, as I said, especially children with long-standing renovascular disease or things like mid-aortic syndrome, they can actually present very clinically well, and they may have been used to this level of blood pressure above the 90th percentile for quite a fair amount of time. So a lot of the literature when we're looking at acute hypertension focuses on the definition of urgency or emergency. These are both very useful for then classifying your hypertension and basing your treatment on the symptoms of presentation. So for hypertension, emergency is very much a sudden, rapid and symptomatic onset of elevation in blood pressure from the baseline. So it's classified as potentially life-threatening with the potential to cause rapid end organ damage. So things like cerebral infarction, hypertensive encephalopathy, cerebral hemorrhage, retinal hemorrhage, papilledema, heart failure, pulmonary edema, or a late-stage AKI, compared with hypertensive urgency, where they may be symptomatic or asymptomatic, and the symptoms they do get are more along the lines of headache, nausea, vomiting, blurred vision, or chest pain. But this is still classified as blood pressure that's 30 above the 95th centile. So management of hypertensive emergencies. So these very much would be discussed with nephrology. Slow reduction of blood pressure is paramount in these patients. There's a high risk of neurological sequel if you reduce it too quickly, especially if you don't know how long they've had this high blood pressure for, or if they're a sudden acute onset, so they've gone very rapidly from their baseline. So the aim is 30% total reduction of BP in the first 12 hours, a subsequent 30% over the next 12 hours, and 30% over the full next 24 hours. Reduction is very much dependent on symptoms. So if you have a child that you have given some medication for and they start to worsen in their neurological symptoms, and become symptomatic of you reducing their blood pressure, you just need to slow it down and reduce it slower. Short-acting agents can be used here, so things like hydralazine, but with caution. A lot of the time, these kind of patients, when they've got blood pressures this extensive in an emergency, should be transferred to kind of an ITU, HDU environment or specialist area with experience in managing this kind of blood pressure, and very much nursed as a one-to-one patient, and maybe used IV medications such as labetalol or sodium nitroprusside, so vasodilators, and these patients should have ideally dual intravenous access, so if their blood pressure is dropping too low, you can give a bolus. You should definitely avoid using angiotensin converting enzyme inhibitors and ARBs when the cause is unknown. So a lot of the time when patients present with these hypertensive emergencies, the cause is unknown. Sublingual nifedipine should be avoided. I have seen some cases where this has been used and quite significant drop of blood pressure from using this medication has resulted in quite a significant neurological state of the child. So renal parenchymal disease, as we discussed, the main cause of secondary hypertension from renal causes. So one of the main things you may see in practice is glomerulonephritis. So hypertension is a manifestation of both chronic and acute glomerulonephritis. It's usually from a post-streptococcal infection. So again, asking about background of medical history and illness. Common mechanisms of hypertension are volume expansion due to salt and water retention here. So this is important to think about your etiology to guide your treatment. So acute treatment of these cases would be with loop diuretics to not only cure the hypertension but the volume overload. You should not use ACE inhibitors due to potential of AKI and worsening AKI. And then indications for referral to a tertiary centre of these kind of patients is severe hypertension that's with worsening renal function. So where you've tried loop diuretics and managing potentially underlying edema or the AKI, and it's not improving and you're needing to consider dialysis. So renal parenchymal scarring. So another linked issue with renal parenchymal disease can be a sequel of an acute pyelonephritis. It may be associated with things like vesiocortical reflux. It can also be seen in children with congenital anomalies of the kidney and urinary tract. So some of these that may be reversible, such as VUR, children can usually grow out of that. An acute pyelonephritis, they can usually have treatment for, and then the blood pressure will improve. And And then those that may be irreversible, so things like renal injury from a previous hemolytic uremic syndrome, where they may get ongoing refractory type hypertension. So I just included this here just because it's a little bit interesting, but it may be something you may or may not see, but it's just important to consider when we're looking at etiology of hypertension. So rarely there are monogenic causes that affect your renal tubular function that can then cause hypertension. So as a general rule of thumb with hypertension that's got a renal cause, it's either going to be glomerular tubular based or it's going to be vascular based. So disorders that usually result in increased tubular reabsorption, so an increase of sodium chloride and therefore water, leading to an increased vascular volume. So this is things like polycystic kidney disease, which can be down to two genetic disorders, so your dominant and your recessive. Your recessive is more common presenting hypertension in children. Liddle syndrome, which is due to a mutation in your sodium channel gene. So this is associated with severe hypertension, low plasma renin and aldosterone levels, and hyperkalemia, metabolic alkalosis, and this very much presents in infancy. Pseudo-hypoaldosteronism may be another one, so type 2, where it's resistance to aldosterone, also known as Gordon syndrome, characterised by hypertension, hyperkalemia, normal renal function, and low or low normal plasma renin activity and aldosterone. So pathway for treatment. So thinking about how our hypertension has presented, is it emergency, is it urgency? The overall goal of blood pressure control in hypertensive patients is to prevent cardiovascular events and renal damage. So the cardiovascular events very much come from adults. There's still very limited data on how much hypertension has affected long-term cardiovascular events in acute pediatrics. And then renal damage. So we know if you have a patient that has an underlying chronic renal condition, that hypertension can not also be a result of that, but can be a causative factor. So the child who does have an underlying chronic condition, hypertension is very much important to manage to slow the progression of chronic kidney disease. So this little table is just very useful to summarise. When you have the patient presenting with hypertension, do they have one or more of the following conditions? Are they symptomatic? Do they have secondary involvement? Do they have organ damage? Do they have diabetes? If yes, it's always leading to pharmacological treatments. Hypertensive emergency and urgency are always pharmacological treatments as well. So just looking at dosing and assumptions about therapeutic risk-benefit ratio, a lot of drugs that are used in children are very much based on adult data from studies of hypertension. First-line treatments when an unknown cause, and you may still be pending some investigations, are a calcium channel blocker. So you could use short-acting like nifedipine, but we would recommend the modified release, not the sublingual or drops. You should use this with caution due to the risk of the unpredictable hypertension, and younger children can get reflex tachycardia. You should always check their serum calcium first, particularly important in younger infants if you're suspecting an underlying renal cause. And then amlodipine is great for a good first-line long-acting treatment for hypertension of unknown. Diuretics as well, so your loop diuretics, furosemide, you may want to consider your potassium sparings, your amilorides, and then spirolactone and metolazone, also good options. Just want to use these in caution if you're considering that the child may have a degree of AKI. So treatment within hypertensive emergencies. So as I said earlier, the treatment should ideally be initiated in the HGU or ITU environment. Sodium nitroprusside is one we use here, and labetalol. Both have their contraindications as listed there and need careful monitoring. Nifedipine we do use, as I said earlier, it's unpredictable for hypertension or reflex tachycardia. Hydralazine is a direct vasodilator. Its onset of action is slower than labetalol, so in the acute environment it is quite good to use. It can be given every 4 hours as well. Furosemide also can be used in the emergency treatment, but you want to be cautious of risk of hyperkalemia. So if you're considering your child may have an underlying vascular cause to their renal hypertension, you want to be cautious about using furosemide because they may already have presented with hyperkalemia. So what other medications do we have as options? So you have your alpha blockades. These are majority used as third-line treatments now for renovascular disease. And then for your specifics, so your renal adrenal tumours such as pheochromocytomas and paragangliomas, they used phenoxybenzamine as a first-line treatment. Beta blockers are also another one, so short-acting can be propranolol, long-acting can be atenolol. They aren't suitable for certain types of cardiomyopathy though, so if you are having a patient present with hypertension that's had an echo done, which may show some elements of cardiomyopathy, caution should be used if you're going to consider starting one of these medications. Care should also be taken when prescribing these for Black Afro-Caribbean, Afro-American groups. And again, they're contraindicated in asthma, portal hypertension and heart failure. ACE inhibitors, so things like captopril, enalapril, lisinopril, they definitely shouldn't be started before all secondary causes of hypertension have been excluded. So especially for any renal causes, if you're suspecting a chronic underlying renal cause, an ACE inhibitor may be beneficial in some cases, such as proteinuria. There was quite an extensive study called the ESCAPE trial done, which measured the effect of ACE inhibitors on the progression of chronic kidney disease, and it actually showed to quite significantly slow the progression of chronic kidney disease with the child who's got active proteinuria. If patients are prescribed these, then they should have close monitoring of their renal function. Contraindication, obviously, in suspected renal artery stenosis, and when the GFR is less than 20. So again, this should be through the advice from the nephrology team. Angiotensin receptor blockers are similar to the above as well for the at-risk group of those that have a degree of renal impairment. So just to summarise, hypertension is a risk factor, not a disease. You're very much thinking about the long-term outcomes of affecting target end organ damage. Consideration of the etiology and pathogenesis is important. So what is driving that blood pressure? Is it volume or salt overload from an acute picture such as glomerulonephritis? Or is it more chronic with vascular complications? Or is it kind of a glomerulus or tubular interstitial problem direct to the kidney? Your etiology will guide your treatment and management. And then the goal of management and treatment is avoidance of end organ damage. So with those children that are presenting with a diagnosed underlying renal cause, such as a chronic kidney disease, their hypertension centile should be aimed less than the 50th, compared to your general population, such as those that are acute hypertension that you'd have an unknown cause for. You're aiming to reduce their blood pressure slowly until you get to under the 90th centile. So I hope that was useful for you all. I'm just going to switch my camera on, and then if anyone wants to ask any questions, you can either use the chat or microphone.